Good afternoon. My name is Mark Burket from Toledo, Ohio. I'll be the moderator for this session. Really looking forward to some of the discussions that will take place today. We have two different sessions that will be addressing drug-coated balloons, an update in 2021, and another session on vessel preparation for complex femoral popliteal lesions. Joining me today on the panel, we have a very solid panel that will be joining us for this discussion. My colleague at the University of Toledo, Raj Gupta, will be joining us. He's an interventional cardiologist with an interest in vascular disease. Also on the panel from the University of North Carolina, Ravish Sachar, who will also give a perspective from the cardiology and vascular world. And then Dr. Soga, who is from Kokura Memorial Hospital in Japan, will also be joining us on the panel. Later on in this session, Dr. An will join us as well. He's from Severance Hospital in Seoul. With that, I'd like to introduce our first speaker, Dr. Thomas Zeller from Bad Krozingen in Germany. Will be talking about a topic that was certainly front and center 2 years ago before it was preempted by COVID, but we're discussing it once again today. Paclitaxel and mortality in PAD. The latest update. Thomas?
It's my pleasure to present the current knowledge about the safety of paclitaxel releasing devices. My potential conflict of interest is my belief in the performance of those devices. This is represented by the 5-year performance data published regarding the freedom from reintervention for the drug-coated balloon by the IMPACT SFA trial, and for drug-eluting stents presented by the 5-year freedom from TLR data from the Silver PTX study, clearly showing that drug-coated balloons are superior in performance over plain balloon angioplasty, and drug-eluting stents are better than what is considered the standard balloon angioplasty with provisional bare metal stent implantation. The background of this presentation is the study which was released by Katsanos and colleagues in 2018, showing a signal for increased all-cause mortality on long term if a patient was treated with paclitaxel releasing devices. However, there was a lot of data missing, and by improving the vital status follow-up and excluding the ascertainment bias, we can see that the hazard ratio showing or suggesting a risk for patients treated with paclitaxel releasing devices was decreasing step by step to almost no significant signal anymore up to 4 years follow-up, including the same studies which had been included into the meta-analysis by Katsanos and colleagues. Here you can see updating the vital status. The risk ratio did decrease from 1.72 to 1.57. This is a decrease overall by 21%. Important to note is that there was no correlation between dose and events. That means that the highest paclitaxel dose, which was used within the IMPACT trials, did result in the lowest mortality rate. As already mentioned, geographic factors may play a role in the outcome of the meta-analysis of Katsanos and colleagues. It's interesting that this signal was only found in patients that had been enrolled into the studies in the US. Out of the US, you can see over here that there was even a trend towards a lower mortality if a paclitaxel releasing device was used. This is underlined by the 5-year follow-up data from the ACOART study from China, showing no significant difference between DCB and plain balloon. However, of note, it's almost a difference of 10% absolute in mortality. So there's a trend towards better survival rate if a DCB was used versus plain balloon angioplasty. And as already mentioned, there is no correlation between dose and event. This is the survival curve for terciles coming from the impact SFA pooled data analysis published by Peter Schneider now 2 years ago, showing the best survival for the highest paclitaxel dose tercile. This is the lowest, and this is the med tercile. Now let's come to real life data. These are two different analyses of the same data set from Germany. It's the Barmer Health Insurance data set. Overall, 65,000 patients had been enrolled into the analysis, treated over 9 years with a follow-up up to 11 years. And basically in the first analysis, within the first year, there was a trend towards a better survival following DCB as compared to plain balloon angioplasty. And in the analysis of the Hamburg group, which was stratified between CLI and claudicant population, there was a significant better survival in the CLI cohort for patients that had been treated with paclitaxel releasing devices as compared to plain balloon or bare metal stent, whereas in the claudicant cohort, there was no difference with regard to survival. For the US, it's very important because the main signal was coming from the US for a potential increased all-cause mortality over time. This is data presented by Sosembski during the panel meeting in 2000 of the FDA in 2019. 150,000 Medicare beneficiaries were included into the analysis, which had been treated either with drug-coated balloons or drug-eluting stents, and were compared with uncoated devices. And basically, the outcome was that there was a significant better survival rate for DCB and DS as compared to plain balloon angioplasty or bare metal stent placement. In a more recent analysis, the SafePAT data analysis, also including a very high number of patients, inpatients and outpatients treated between 2015 and 2018, with a mean follow-up of 2.7 years, which is meaningful. So that means the longest follow-up was 5 years. Again, there was a significant better survival rate for patients that had been treated with paclitaxel releasing devices as compared to bare devices. Last year in the New England Journal, an interim analysis of the SweetPAT randomized controlled study was published, again showing no difference, no mortality signal if drug-coated devices had been used. This study includes patients consecutively treated in Sweden. These patients are randomized before treatment between a bare metal stent or drug-eluting stent or DCB versus plain balloon angioplasty for CLI or claudication. And the most patients included into this study have been treated with Femoral-Popliteal lesions. This is the patient cohort included into the meta-analysis. Another analysis, a sub-cohort analysis, comes from the Voyager study. This was a study mainly designed to evaluate the impact of low-dose rivaroxaban treatment following interventional treatment in femoral popliteal lesions as compared to placebo. So it's a double-blind, randomized controlled study, clearly showing that there was a primary endpoint benefit for low-dose rivaroxaban treatment as compared to placebo treatment with regard to the onset of acute limb ischemia, major amputation, myocardial infarction, ischemic stroke, and cardiovascular death. In a post-hoc analysis looking on the impact of the use of drug-coated devices, there was basically, again, no difference between paclitaxel releasing technologies and plain devices with regard to all-cause mortality over a time of 4 years follow-up. And looking on the stratification with regard to DCB versus PTA or DES versus bare metal standing, absolutely no difference. So there was no risk if a patient did receive a paclitaxel releasing technology. On the other hand, there was a significant better outcome with regard to unplanned index limb revascularization if patients had been treated with paclitaxel releasing devices. This is data from our own institution. It's a retrospective analysis, but it's consecutive patients comparing patients that had been treated with paclitaxel coated balloons as compared to plain balloons. This is a patient cohort which was absolutely paclitaxel naive during their follow-up, and we found a significant better survival if a patient was treated with paclitaxel coated devices. Important to note, what is the mortality rate in a real-world setting if patients had been treated with drug-eluting balloons? This is 5-year mortality data from the IMPACT Global study. Mortality overall in this patient cohort of 1,500 patients was 19.5%. And how does this relate to epidemiological studies? This is 5-year mortality rate of a claudicant cohort with or without diabetes. This is 38% mortality for a claudicant cohort without diabetes, which is for Austria, and this is for the United Kingdom. And this is higher as compared to what we found in the IMPACT Global study. So if we compare these data, again, there is no signal that treating patients with paclitaxel releasing devices results in an excess all-cause mortality. So in summary, the meta-analysis by Katsanos and colleagues with a suggested excess mortality following paclitaxel-coated device treatment for femoral-popliteal artery disease was a single finding without confirmation in large real-world studies. There was no dose response and no mechanism of action why paclitaxel exposure should result in an increased mortality. The signal diminished with vital status ascertainment. The signal primarily was observed in the US. Paclitaxel-coated DCB and DES are to date the most clinically and cost-effective interventional tools for the treatment of even complex femoral popliteal artery disease. Withholding such devices to patients with severe peripheral artery disease may even harm them and results in increased global healthcare costs. The question is, when will the agencies recall their warning? I thank you for your attention.
Thank you very much, Thomas. That was an incredibly exhaustive review of that controversial topic, and I can't wait till the discussion portion at the end to see what we do with that information. So thank you very much. We're going to move on to our next speaker. At least I hope we can get his slides up. This will be Lawrence Garcia, my friend from Boston, who is a professor of medicine working at St. Elizabeth's Hospital. Let's see if we can get Lawrence's slides up as he talks about drug-coated balloon therapy and femoral popliteal disease. What's the latest?
Very good. Hey, Mark and the rest of the group, and for to all our colleagues in Seoul, thank you very much for the kind invitation. That was a great talk by Tomas, and some of this will be repetitive. We're going to look at the current update. What's the latest for femoral popliteal disease? These are all my disclosures, some of which are germane to this topic. As Tomas already alluded to, we're really talking about DCBs and what's the latest, driven by this manuscript from a couple of years ago by Katsanos and colleagues. And this urgently warranted effect is driven by this shift in this Kaplan-Meier and this forest plot, all to the right, with the ultimate 5-year risk being almost 100%, a 0.93 increase, 93% increased risk of some outcome that was poor. So the safety questions were raised in the United States, and it really turned into this moratorium that the FDA drove. And our FDA met in a panel in 2019, and there were no changes to this moratorium. So the update in August really did not give us any direction in the United States. And despite, as Tomas had suggested, the decline was clear, it still raised questions of a hazard ratio of almost 30% to 40% risk, despite the real world patient level data. Tomas has shown some of Peter's data presented at both at panel and also published in JACC. When you look at the breakdown of the tersile risk, there was no evidence in probably the best overall program, which was the Medtronic program, at overall risk of mortality. And the outcomes, as we already know, are actually quite good in patient populations that we already need to treat. The overall outcomes when it comes to benefit in our patients with femoral popliteal diseases with Semsky's paper, both the smaller group, 19,000, and then the 153,000, this has some inherent potential confounders in the Medicare data set that is critical and should always be taken when a meta-analysis of this size is taken out of Medicare data. But looking at the risks over time, these were relatively flat, and that does give us some pause to the overall potentials. So what's happened over the last couple of years? There have been several trials, two that I want to focus on. One is dealing with atherectomy and DCB as a combination. The laser, which builds on the original PhotoPack data set, was just published this past year, and it looked at the outcomes using the Spectranetics, now Philips laser in treating the Tosaka 2 and 3 in-stent restenoses at both a 12-month and a 24-month outcome. And you can see that the lines are relatively parallel. When the assessments occur at the 12-month time frame, they tended to separate. They remain separate for the following year and then recombine, such that at the 12-month endpoint, it was about a 20-point difference on TLR. Remember, this is not a primary patency, with excimer laser having the benefit for a population that was relatively long in-stent restenosis. And at 24 months, it truncates down to only 6 points. But you can see that it is still a fairly highly charged environment in patients who restenose over time using a TLR metric. That if you get a 1-year outcome that's relatively good in these patients, it is still considered a victory, but we do see a decline at 2 years. When looking at the worst of the worst, which would be Tosaka 3, the benefits are a bit more muted. They're still very good at the first year, but they tend to decline relatively quickly out. And these, of course, are in smaller patient populations as you go out. Drug-coated balloon at 2 years, this is the FPAC trial. Tomas touched upon it. 171 patients, they were randomized with DCP compared with POBA alone. The Kaplan-Meier difference was highly statistically significant, but a 90% primary outcome compared with 67% with simple balloon angioplasty on a lesion length that was not too short and fairly moderate in length. What is most interesting is that at 2 years, this is almost exactly the same. If you go way back in our data set to the original Absolute trial from Vienna, at 2 years, there is no difference in the clinical outcomes of this POBA group, despite having an anatomic decline in patency compared with the DCB group, and the clinical outcomes are relatively flat. And there was, again, this no difference in mortality that Tomas was focused on. I think one of the biggest trials to date that I think is an important one is the scar equivalent in the periphery, which was presented in the New England Journal just this past December. And the overall population of about 2,200 or so patients in this population showed, again, drug-coated device was really flat when it came to the overall mortality. This was really driven to outcomes of mortality, not really to primary patency. And whether it was chronic limb-threatening ischemia or our simple claudicants, you can see that the difference between the mortalities, we already know that the patients with critical limb die more often. They have a higher mortality than those with claudication. And I think that this showed that very nicely. I think it ended up in the New England Journal because it does have a lot of the supportive data that the New England Journal focuses on to give us this very strong paper and should be considered a seminal paper when it comes to the outcomes in femoral popliteal disease. So the unfortunate truth is for kind of the latest and what's up to date, more recently, the FDA panel looked at below knee DCB, and this was driven by the Lutonix data set, and it did not endorse BTK DCB use. The lack of endorsement is due to a lack of data compared to POBA alone when it comes to below the knee data. The overall data is really mitigated to a no difference outcome when it comes to below knee therapies. And I think that is kind of critical when it comes to where the future of drug-coated balloon technology is when it comes to the lower extremity, and then when you move on to below knee. I would highly agree, and it would, well, it'd be very hard to disagree with my colleague Tomas, but I would highly agree with him in that DCBs have dramatically changed the SFA landscape. The durability at 5 years are absolutely in favor of drug-coated use. The healthcare costs, at least in our country and throughout the world, I do not know of one study that doesn't show that it favors DCB use. DCB data and combination therapy, I didn't show the reality data that was presented at Viva this year. It really appears successful in the myriad of patients that we treat, from the simple to the most complex, for outcomes that are actually beneficial to our patients. And that benefit is not only clinical, i.e. they feel better and they can walk further, or you have limb salvage, but more importantly, it's a durable outcome beyond the index procedure, and the economics would highly suggest its continued benefit. I am very disappointed that the FDA has not updated their guidance. We're coming up on the second year now from their above knee guidance, and I look to them for at least some support as we move forward from this moratorium and trying to really go through the gymnastics for our patient population. But the below knee guidance right now suggests there's no benefit for the DCB use for our patients for below knee until some other device company or some other trial comes out with support. So far, there is no new guidance from the FDA that would allow their use. And I think that with that, I will close my talk, and I thank you for your time.
All right. Thank you very much, Lawrence. I think that really helps to kind of fill out the picture a little bit more clearly about where we stand with drug-coated balloons in 2021. I'm sensing a little frustration with the FDA. I think what we'll do now is move on to our next talk, and then we'll reserve the discussion for after Bill's talks. This is my colleague and friend, Bill Gray from Philadelphia, who serves as system chief in the Division of Cardiovascular Disease at Lankenau in Philadelphia. And he's been tasked with talking about the infrapopliteal application of DCB. Bill?
You know, before we get too far down the road with this, I wanted to discuss, the goals of revascularization and critical limb ischemia BTK. This is a chart which I like because I think it really summarizes or frames the whole issue of BTK intervention. In a patient who has no disease, there's what we would term optimal vascularization. For patients with disease, there may be vascularization, not optimal. And then but hopefully it's above the metabolic need, which means that there will not be an open wound. There may be pain, but not an open wound. Induce some trauma, your metabolic need goes up. your vascularization is not adequate to supply that metabolic need, and therefore you create and maintain a wound. We then come along and revascularize a BTK lesion. The metabolic need is then satisfied by the increased perfusion, and the wound heals. And then after the wound heals, we can go back to a non-patent or restenotic segment as long as it maintains a perfusion greater than the metabolic need of a non-wounded leg. So with that background, let's look at some of the clinical data. What we know, if we look at a broad range of revascularization studies, that there's a clumping of limb salvage around 12 months at about 90%. And if we look even more closely, we see that bypass typically is more effective, and these are older data for PTA, but nevertheless proves the point that while bypass is more effective at 1 month, 1 year, and 3 years at maintaining patency as compared to PTA, in point of fact, limb salvage is not materially different between them, in spite of the fact that patency is worse, documented worse. And I think that goes to the original schematic that we went to, and is one of the issues around proving effectiveness of a device which is going to improve long-term patency. So let's go to some of the detail now. So I'm going to skip over this, but I wanted to come to here. This is a nice chart of many of the data sets that are available for BTK intervention for angioplasty alone. And if we look at it, the overall average, again, different types of populations and so on, but the overall average is about 50% patency at 12 months. And that's a low bar. And yet we still don't have anything, as I'll show you in a moment, that really matches it. So this is a single center study from Listro looking at impact and Furion in diabetics. And it was a successful trial. It was non-blinded, but it was randomized, relatively small trial. But you can see that across the board, no matter how it was sliced, that DCB appeared to be more effective than PTA. And here's the Kaplan-Meier analysis of that trial. Unfortunately, every trial that came afterwards was unsuccessful. The granddaddy of them all, Tomas, led this trial, was the Impact Deep, which was unsuccessful, published in 2014. And again, no matter how we slice it, it looks like there's no advantage to either arm in any meaningful or significant way. If we look at the IDEAS trial, we see again DCB versus DES. DCB does not measure up to DES. You can see that here. Late lumen loss is not significantly different, but restenosis does appear to be worse with DCB. And interestingly, not unlike what we talked about before, wound healing is not materially different, even though the patency for DCB was not as good as DES. The patency outcomes, the clinical outcomes, were not significantly different between the two. The Biolux P2 trial was also unsuccessful in a randomized multicenter attempt to look at a novel DCB device. And you can see here that there was absolutely no difference in patency between the two arms of the trial. The most recent trial that is worthy of discussion is Lutonic's Global BTK study. This came before the FDA last week. Lawrence had alluded to that. The FDA panel voted pretty strongly that it was a safe device but not effective, and therefore voted not to approve the device for use. It was a large device randomized 2-to-1, large trial randomized 2-to-1 across 3 sites, US, Europe, and Japan. If we look at the lesion sets, they're reasonable lengths of lesions, and the calcification grade was actually fairly significant, which is not common in many of the trials, which I'll show you in a moment. So it was a representative lesion set. The problem is that when we look at the clinical parameters, we see that Rutherford 3 and 4, if not predominated, were co-equal with what we would consider meaningful critical limb ischemia in Rutherford 5. This was one of the things the FDA panel picked out as a problem in the trial. This was expanded during the trial in order to improve recruitment. The trial actually never did finish. It was supposed to enroll close to 800 patients and only enrolled something like 450 patients. And that was another problem with the trial that the panel picked out. This clinical data is underlined by the fact that there's at least almost 10% of the patients had popliteal disease as their primary lesion. Here are the major endpoints, not really worth spending time on, but the 30-day safety endpoint was satisfying in the sense that there was no difference in safety between the two, and given the issues around paclitaxel safety, this is good to see. The Kaplan-Meier 6-month efficacy was demonstrated to be better for the DCB arm, but this was a combination of limb salvage plus primary patency, and primary patency didn't necessarily translate into limb salvage in this trial. And so their clinical effectiveness was not as meaningful. So what are some of the potential causes for DCB failure? Well, one of them is that patients in this population die fairly significantly at 1 year. In the BioLux trial, almost a quarter of the patients died, and in the Impact Deep trial, over a quarter of patients died. So this makes follow-up and meaningful analysis of the effectiveness of the BTK DCB difficult. This is the impact root cause analysis. I will just circle that probably the biggest issue was that the balloon material really did not promote drug delivery. There were other issues related to favorable PTA amputation rates, which again, in a trial of a relatively small number, can be seen. Some people bring up the issue about calcium. This is from Fabrizio's work, and it's maybe the most commonly shown chart in all of DCB world. But we know that calcium probably does contribute to lack of patency. The problem with that is that severe calcification in many of the trials we talked about, other than the Lutonix trial, wasn't really seen very often, and really in low double-digit numbers. So it can't really be a major cause of failure. I want to end with a provocative trial, which is from a solution company. Metalliance is the company that makes it. This balloon is a microreservoir sirolimus-eluting balloon, which actually has microreservoirs of sirolimus rather than paclitaxel. This was presented from Singapore General Hospital at LINC this year, called the Prestige trial. And at 6 months, quite interestingly, a single-arm trial showed very robust data. We see that go back for a second. We see that freedom from target lesion revascularization is over 90%, amputation-free survival 85%, and primary patency of over 80% at 6 months, which is pretty good, but again, not randomized. But a difficult population, 88% had diabetes, 100% of the patients were Rutherford 5, which is good, and many of the patients were at risk because of their Wi-Fi baseline score. And at 12 months, we see that the 6-month data actually holds up pretty well, and then we see that death, amputation, and TLR maintain at a relatively low rate. So overall, this is appealing, it's tantalizing, but it doesn't necessarily speak to the need for randomized data below the knee. So in summary, there remains very little randomized data supporting the clinical efficacy of DCB below the knee. Specific causes may include calcification, the high frequency of death and early follow-up, disassociation between patency and clinical outcomes. If the whole premise of DCB is that we are looking at a device which improves patency, that may not be apparent in the clinical outcome because of what we talked about at the beginning. And then lastly, and again provocatively, potentially paclitaxel is not effective below the knee. Why that would be biologically is not yet clear. And so we await novel approaches with non-paclitaxel therapeutics, which are currently in process. Thank you very much.
All right, thank you very much, Bill. That really, I think, kind of expands what we were talking about earlier with the clear signal in the femoral popliteal segment with benefit, and then we go below the knee and everything gets kind of confusing and hard to explain. We have a great panel, and we have, by my calculation, about 11 minutes for questions. I'd like to see if some of my fellow panelists have questions for any of the lecturers. I'm going to see if we can draw some out. Ravish or Raj or any of the other panelists, any questions?
Thank you. Just a question and also just an overall perspective on the US side, as we heard from Tomas and from Lawrence, the FDA has not reversed their recommendation. How are practice patterns despite that? Have practice patterns reverted back to what they were before? How are things in the rest of the world? Just wanted to get everybody's thoughts on that.
Well, at least in the US, I can say at our institution, we really never took much of, we never took the Katsanos data to heart, and therefore did not modify much of our practice. We increased obviously the conversations with our patients, but in general recommended that paclitaxel still be used, and it was part of our standard practice. So I know that there were extremes, Ravish, with including people taking everything off the shelf, from that to implementing informed consents with special language around paclitaxel. We chose not to do either one of those. I think that the larger data from industry, as I understand it, is that there's been a rebound in use of paclitaxel, although it hasn't achieved what it was pre-Katsanos.
Yeah, well, I can speak at least for Germany. It's the same situation. The high volume centers did not change their strategy with regard to use of paclitaxel releasing devices. All of us did look into our own data sets as shown in my presentation, and there was no signal for an increased mortality risk. So we did continue using DCB and DS. The problem is that also the German agency BfArM is looking what the FDA is announcing, and as long as the FDA does not move away from their warning, BfArM will not do it as well. So this is, you need to convince your agency, the FDA, to rediscuss their warning. And I don't know what they are looking for and waiting for, what additional data they need to change the warning.
Yeah, I think if they saw the accumulated data that you showed us, Thomas, that's pretty convincing. And I think that many of us, kind of like Bill, just never bought the original proposition that there was an association between paclitaxel and increased mortality. And I think even further, it became very difficult when you try to discuss this with patients. A patient doesn't understand what a meta-analysis is. And when you sign a patient up for a procedure, the possibility of death is already in there, and the possibility of restenosis is already in there. So really, you're not introducing anything new to the patient. Yeah. So I think it just put the doctor in a very tough position and made life very complicated for all of us.
Mark, if I could add one thing to that, to Bill's original point on what you just described, we were in the world of a conglomerate telling us that we had to take everything off the table. So we went to the moratorium that the FDA used. And the challenge is if you really wanted to practice medicine from early 2000 where we had nothing, this is exactly what I've had to endure for the last year. And only when we saw our patients return with restenosis where they would not have otherwise, that is the only way. Now we have a special consent, but to your point, it's a pain in the rear end to try to discuss the meta-analysis with patients for them to understand any idea of what this meant. But what they do realize is they came back more often. And so now it re-swung back up to pre-use. But it's taken a year for the network that we work within and our CEO, everybody underneath him, to allow us to get back to that level. It's been a real shame.
Yeah,
Mark, I can comment one other thing which I think is salient here. We're working. There's a group of us physicians independently working with the consortium of relevant manufacturers in the United States with the latest vital statistics complete data, and we're about to complete our statistical analysis plan, and that plan will hopefully go to a CRO, and the data will then be taken to them. And the good news is the data is now almost 95% complete across the board, which is significantly better than the 75 to 80% complete that it was previously. In addition, there's now 5-year data on 2 Philips studies, which add to the larger numbers. The fundamental problem with Katsanos was that by the time you got to 5 years in that trial, you went from over 4,000 patients in the one year 28 trial analysis to 5-year 800 patients, 3 trials. And that leaves huge error, type 1 error opportunity. So I think this next analysis that we're doing hopefully will address all those issues and show something a little bit different, but we don't know yet.
Right. One of the things I wanted to pose to any of you, perhaps to Tomas in particular, when the Paclitaxel signal first started being discussed, it seemed like this is a great opportunity for anybody who's got sirolimus in the pipeline, that now there would be an alternative to Paclitaxel. But now as the pendulum starts to swing, maybe the advantage that sirolimus had is not such a clear advantage. Where does this leave sirolimus in 2021 and 2022?
Well, basically, sirolimus is facing the same problem to prove not only efficacy, but also safety. Well, even if everybody believes that sirolimus is the safer drug, the data that are presented, they are related to local toxicity. It's not related to systemic toxicity. What does that mean? In order to avoid the same discussion we had with Paclitaxel, all upcoming sirolimus trials also need to implement a safety long-term follow-up with regard to proving that exposing a patient to sirolimus does not harm the patient. So this is number one. That means there will be an extended follow-up needed to get I would say the approval for liberal use by the FDA, for example. They will ask for longer-term safety data. They will not simply focus anymore on efficacy data. This is number one. Number two is if Paclitaxel will be used again more liberal, it will remain the cheaper device because the limus-coated devices will come to a premium price to the market. And therefore, it will be hard to get a significant market share for limus-coated devices.
Great. So it's an uphill battle. Other questions from other members of the panel?
I have questions for some regarding to the Paclitaxel issues. If the DCB had a better efficacy, shouldn't it have a result that eventually lead to an increase in survival rate? So is there any possibility of offset effect of DCB in safety issues? So I have some, is there any chances for offsets of benefit and efficacies and harmful effect in survival, some no differences in outcomes?
Well, basically, what the real world data analysis from, for example, Medicare beneficiaries or Barmer health insurance company data, they show a benefit in terms of better survival after treatment with drug-coated devices. I don't believe that this is true because the drug is supporting survival. It could be, and that's what we had been hoping from the very beginning. If we can better ambulate our patients, that they change their lifestyle, that they walk more frequently, that this change in daily behavior may increase their survival rate. And I don't know whether this is a real signal which is coming from the better patency outcome, but certainly it should be discussed in this way.
Additionally, the reduction in repeat procedures can also somewhat lower the risk of adverse outcomes with repeat procedure and mortality, perhaps.
Yeah.
Both of those should or underscore, I think, what you see in the larger registries, both Medicare and Barma.
So I have a question about below the knee drug-eluting device use. Though we know from the prior speaker, the evidence seem not so favor the DCB, but in real world, like in our center, we still use a lot of DCB for below the knee intervention, and we did not see a high TR rate, and we also do not worry about the safety issue because we have even a lower mortality rate for the DCB use in SFA disease. So I don't know, should we stop all the DCB use for the BTK lesion, or any comment about this?
Well, I mean, so I don't have any experience with BTK DCB, so I have to defer to you on that. But the data sets don't support it. Now that doesn't mean that there's no effect. There's not an effect there, but it's not been demonstrable in the randomized trial data sets. And as you know, DCB, treatment below the knee is confounded by the fact that patency is difficult to assess non-invasively, and wound healing can occur even with a loss of patency in the intermediate term. So again, not questioning your experience, but difficult to know what to make of it given the randomized control data.
But on the other hand, there is data for two new Paclitaxel eluting balloon brands. One is the lightest balloon from Ecotech. One is the following device from Medtronic, the new BTK device. And even if the studies did not enroll that many patients, these are randomized controlled data clearly showing that a Paclitaxel coated device can be effective even below the knee. So probably it will change our attitude in the future. And in my institution, we are treating long diffuse lesions in almost 100% now with DCB again, using the lightest balloon, which has been shown efficacy in the ACRO-ART2 study in China, but also in Italy. So there are brands available, not approved in the US, obviously, but out of the US, which are really effective. And they did show a trend towards lowering amputation rate in the small studies.
And I think that's the thing, Tomas. I know about those trials, and the problem is that it's the clinical output that is problematic. The patency output may be something demonstrable, like it was in photonics, but difficult to make the clinical argument. That's the only thing I think that I was trying to.
Sure.
So I'm not against using them. Believe me, I think of any population that should be maintained patent, it should be that one, if at all possible. But proving it's tough.
Yeah, I think the thing that has us all scratching our heads is these things have been proven unequivocally to be beneficial in the femoral popliteal segment. All of us who put in coronary stents wouldn't think about putting in a bare metal stent anymore. We'd use drug-coated. And what is it that makes the infrapopliteal segment so different? You know, I think that's what we're all struggling to understand at this point. So thank you very much to all the presenters. Those were excellent presentations, good discussion. We're going to move on to our next session. And leading off for our next session is Dr. Ando, who is chief of Kasukabe Cho General Hospital in Saitama, Japan. And he's going to be talking about non-atherectomy strategies for vessel preparation in complex femoral popliteal disease. So Dr. Ando, it's all yours.
Thank you. I'd like to start my presentation.
Thank you, Chairperson. I'm glad to have a chance to speak in this conference. So today I'm going to talk about non-atherectomy strategies in FP lesion. There are many atherectomy devices in the world, but in Japan, we can only use lasers. However, lasers are also allowed to be used only for stent restenosis. That's the first in the FP lesion. The evidence is very uncertain about the effect of atherectomy on patency, mortality, and cardiovascular event rates compared to POVA. However, atherectomy device has an important role to play in overcoming difficult situations such as calcification, thrombus, ISR, non-stenting zone, and device delivery failure. But as mentioned before, they can hardly be used in Japan so we will make various efforts to confront difficult situations. First of all, for calcified lesions, aggressive vessel preparation using super non-compressed balloon, super high pressure balloon, and scoring balloon is a basic procedure. In addition, various techniques are used to perform lesion modification and overcome the difficulty of balloons not passing through the lesion. I can't talk about everything today due to time constraints, so I will introduce some of them. This is an example of most common vessel preparation. You can see a severely calcified SFA CDO, a small vessel with an EM of 4 to 5 millimeter on IVUS. I chose a 6 millimeter super high pressure balloon and performed high pressure expansion. After obtaining sufficient lumen, a spiral stent was inserted and post-dilatation with a 7 millimeter balloon was done. Of course, whenever we expand aggressively, beer bun is always prepared for rupture. This is a case with Cannon technique in the calcification and non-stenting zone. You can see the calcification nodule of CFA straddling DFA and SFA. In this case, the soft wire was first passed through the true lumen beside the nodule. After that, the second stiff wire was passed through the center of the nodule and performed balloon dilatation. Then, the two wires were inserted into a 0.35-inch compatible over-the-wire balloon at the same time and successfully passed the lesion. This means that by expanding the center of the nodule was successfully connected to the remaining true lumen, and the two guide wires were in the same space. Then KBT was done. Finally, using DCB, I got satisfactory result, although may have had better result with an atherectomy. But this technique would make it possible to avoid stenting. This is another case of Cannon. For a calcified nodule, I use a stiff wire or wire tail to pass through the center of the lesion. And finally, I succeeded in passing the lesion using Almet and very stiff tapered wire. And I expanded it with a scoring balloon and finished it with DCB. In this way, a large lumen can be obtained by passing the guide wire through the center of the calcified nodule rather than passing it through the lumen remaining next to the calcified nodule. Bravo technique is an abbreviation for biotome assisted by Rambo via Optimo. This method was introduced by Dr. Yoshito Yamamoto of Iwaki City Medical Center. Rambo technique is a technique introduced by Dr. Urasawa, in which a crosser device is placed on a double-banded guide wire to floss calcified nodules. Optimo is a sheath with a balloon that prevents distal embolism. The Rambo technique detaches the calcified nodule from the vessel wall and removes it with biotome. This is a Bravo technique. He concludes that this method is very safe and can be an option for the treatment of non-stenting zones with calcification. Fracking technique was introduced by Dr. Takuya Haraguchi of Sapporo Heart Center. I think fracking is an unfamiliar word, but fracking involves the injection of water, sand, and chemicals at high pressure into the shell layer to crack so that natural gas from the shell can flow up the well. Inflate a properly sized balloon to push out calcified nodule, increase density, and prevent unexpected dissection. Then insert the 18-gauge needle into the target of the calcified plaque. Attach a 3-millimeter lock syringe to the needle and inject saline through the syringe to check the needle tip position. The syringe plunger cannot be pushed after the tip of the needle has reached dense calcification. At that point, replace the syringe with an indeflator and inflate. At the same time, the calcification is destroyed, the inflation pressure suddenly drops, and the contrast medium seeps out under fluoroscopy. The fracking method is repeated until no fracking point is found or contrast agent in the interpreter runs into the SFA. He concluded that fracking technique could take more lumen than the lumens obtained by common SFA standing over after jet stream and over after lithoplasty. And primary patency and freedom from TLR were higher than over. In addition, there is no safe issue. Needle cracking technique is a method I have been using for more than 10 years when balloons do not pass due to the calcification of BTK and BTA as well as SFA. I will show you a case. The balloon did not pass due to the calcification after passing the wire, and neither clustering nor tonus in this case. So I inserted an 18-gauge needle from the body surface into the calcified region to crack. Lesions are often very hard and need to be inserted while rotating the needle. After repeating this several times, I finally succeeded in passing the balloon through and expanding the calcified region. After the stent was deployed, angiography revealed extravasation, so a needle was inserted into the hematoma and thrombin was injected to stop bleeding. And finally, complete hemostasis was achieved and blood flow was successfully restored. There is no very effective method for ISR. CDT is often done after aspiration and dilatation using small balloon, but it's not so effective after all because DCB cannot be used for ISR in Japan. Stent-in-stent using DES or Biabar implantation are also performed in some cases. There are several unique techniques to deal with thrombus and embolism, especially if they are in the non-stenting zone. I'd like to introduce reverse Fogarty technique today. You can see a total occlusion of CFA and floating thrombus on IVUS. The problem is that there's thrombus in the non-stenting zone. Therefore, a 5 French sheath was introduced from the proximal SFA and the Fogarty catheter was pushed to move the thrombus to the EIA. Angiogram showed that the thrombus has been pushed away and does not remain in the CFA, which is considered a non-stenting zone. Subsequently, the stent was placed and deployed beyond the thrombus and Fogarty catheter from the contralateral side, and the thrombus was sandwiched between the arterial wall and stent. After post-dilatation, I could restore blood flow nicely without distal embolism. In conclusion, in the absence of an atherectomy device, aggressive vessel preparation is performed for calcified regions, and special techniques are used when in the non-stenting zone. DCB cannot be used against ISR, so a tough battle is forced. Thrombus and embolism are aspirated or covered with a stent, but if they're in the non-stenting zone, they are moved to the stenting zone and covered with a stent. Thank you for your attention.
All right, thank you very much for that presentation. There's a saying that necessity is the mother of invention, and I would say in your situation, the necessity has really produced quite a bit of creativity. Thank you for that. I'll be interested to open your talk up for discussion following the next two, Dr. Ando. Next, we're going to go to Michael Lee from UCLA, who is going to talk about orbital atherectomy and the femoral popliteal lesions, some advantages and limitations. So we'll turn things over to Michael Lee.
Well, good evening, everyone. Thank you for the kind invitation. And I guess in some places in the world, also good morning for those on the coast. It's certainly a pleasure and honor to be a part of this session with some real legends and Hall of Famers here. So we've all encountered complex calcified lesions. We know they're more complex in terms of procedural techniques and are associated with worse long-term. So some of the devices that we have in our toolbox include laser atherectomy. However, for very severely calcified lesions, laser is generally ineffective. Maybe an option for, let's say, mild to moderate calcium, but for severe calcium, probably not the best tool in our toolbox. What about directional atherectomy? In my experience, for those lesions that are severely stenotic, it can be difficult to traverse the lesion with a device, perhaps using pre-dilatation with a balloon. Then advancing the directional atherectomy device is an option. This also requires a bit more skill. I remember Lawrence was doing a case in Korea, and he was master, and watching him torque the catheter, and you have to do 4-quadrant cuts, but it is somewhat more technically demanding to do. What about jet stream? It is an option. Once you have the wire through it, it's reasonably easy to perform. But for femoral lesions, you do need a larger device. It does require a 7-French sheath. The device that I use, my preferred modality, is orbital atherectomy, and it's a relatively easy device to use. Once you have the wire across, it just involves advancing the knob very slowly, 1 centimeter per second. You have your assistant flush with saline, and you kind of listen to the high-pitched squeal that you know that you're atherectomizing, and just by touching a button from going from 60 to 90 to 120, you get more atherectomy at higher speeds. We're all familiar with this device, but just to go over, this device works in a bi-directional fashion. So unlike, let's say, laser or directional, when you advance the device, you're atherectomizing, but when you're also pulling back, you also atherectomize as well, so that has the added benefit. Number two, when this device is activated, not only does it rotate, it orbits. So it does have contact at 360 degrees on the vessel wall. So perhaps it facilitates blood flow and decreases the risk of slow reflow and distal embolization. So what are some of the data that we have with this device? In general, it is safe. If you look at the rates of perforation, the highest rates that were recorded were upwards of about 1.6%. But in the largest series we have with Confirm, we're talking about 0.7% risk of perforation. What about flow limiting dissection? Well, some of the smaller studies, let's say, for example, the Truth, which included 29 lesions and 6.9%, but some of the larger studies, 2.0% flow limiting dissection. It may be related to the fact that it's not only rotating, but also orbits. So you do have perfusion down the limb when you are active. What about the risk of abrupt vessel closure? Well, again, Confirm. Very low risk of abrupt vessel closure. We're talking 1% here. Distal embolization and Confirm 2.2%, very acceptable, especially when you're dealing with these long FP lesions. In slow reflow, no reflow, 4.4. Some techniques that you can do to decrease the risk of this complication includes liberal use of vasodilators, nitroglycerin up to 400 micrograms, waiting, being patient, advancing the device slowly. So we talked about plaque modification. One thing that this device does is when you kind of change the compliance of the vessel is that you don't need to go to high pressure balloon inflations. If you look at these 4 studies, the average ATM that you had to inflate the balloon to profile was ranging from 4 to 5 atmospheres. So you're not even getting to nominal pressures here. So operators feel comfortable inflating at low pressures. So when you have a low mean maximum balloon pressure inflation, it requires at least less dissection. And when you have less dissection, you have less rates of bailout stenting. So it obviates the need for stenting when you have long dissection planes. So it does do its job by decreasing to some degree the plaque burden, but the main benefit is that you get plaque modification and changing the lesion compliance. Now we talked about the acute procedural complications. What about long-term benefits? Well, this is the orbital atherectomy subset of patients in the Liberty study. So let's take a look at Rutherford class 2 and 3. So very acceptable at 2 years. We're talking freedom from TBR, TLR, very acceptable. Freedom from major amputation or limb loss on a target limb. Nobody required amputation in patients who had Rutherford class 2 to 3. So very safe and effective long-term. So one potential benefit of orbital atherectomy is that it has a very long shaft, and this will permit you to do radial intervention. You know, there was a paradigm shift, let's say about a decade ago, where we're looking at ways to improve the safety of PCI. And one way to do this was to decrease vascular active site complications. And that's why there is a shift towards doing transradial intervention. Let's talk about the thermopoctival lesions. We've all been there. We've seen these iliac arteries, which are hostile. This patient, for example, has a very acute angle. He has a reconstructed carina where there's 2 stents high into the aorta. So imagine trying to go up and over. It's nearly impossible, even with the best of sheets, to go up and over. This is an example here where you have access, then you're going posterior, superior, horizontal, up and over, sharp angle. You know, there's some techniques to get this sheath, and we have very good sheaths, for example, to remote destination, etc. You can advance a balloon to inflate, anchor, advance forward, but there's another way to do this. So why radial? Well, number one, it is more technically easier to do by advancing stents or balloons from up on top. You have less vascular active site complications. Patients can leave the facility faster, and again, just less bleeding complications. You know, if we do 100 cases and our success rate is 98%, I don't remember those successful in 98 cases. I remember those 2 horrible vascular active site complications where that bleeding, holding pressure, they're hypotensive, you're calling vascular surgery, and you have poor access, you gotta go up and over, get an 8 French sheath to put in a Viabond to get hemostasis. So what can we do? I think radial is a very good alternative. So there are various ways to approach patients. What I like to do is the following. Similar to how we perform coronary intervention, we're standing on the right side of the patient. All I have the patient do is have the patient's head go where the feet would have been and vice versa. So they're kind of flipped upside down. I put their arm at a 90-degree angle, and I put the table perpendicular to the patient. So I'm standing here, I'm looking straight down, and I have the monitor right here. So we get access. We typically use a 5-cylinder sheath, take a turbo, check that, a VersaCore wire down and through, let's say, a 150 centimeter Navicross. Once you get a wire down, you could advance a turbo destination, let's say 149 centimeters, to the iliac artery of your choice. And from there, you could approach and attack the Thermopoctival lesion. As I alluded to before, the benefit of orbital atherectomy is that the shafts are long, so upwards of 200 centimeters. So allow you, for a patient, let's say 5'7", and I prefer to work from the left side because working from the left radial artery buys you about 15 centimeters more compared to standing on the right side and working from the right radial artery. So if you have a 5'7" person, you have a 200 centimeter shaft, you could probably treat down to the distal esophageal 200s canal. You also need to have longer wires. So the beauty is that the Viper wire is 475 centimeters. So it's a wonderful wire to work off of. And with that table being extended, you could make your loops and have your assistant help you. If we look at the REACH PVI study, these were 50 patients. This was a single arm, multi-center study looking at the outcomes of transradial peripheral intervention. Majority of the lesions were femoral lesions, but actually some patients even got interventions of the below knee lesions. Majority of the patients underwent transradial access from the left arm, and most patients had a 6 French sheath put in. I would discourage using a 7 French sheath, although it is possible if the radial artery is large. The beauty also with orbital atherectomy is that you could use a 5 French sheath. So smaller devices less bleeding complications. Stents were placed in 16% of cases. There was one angiographic complication due to dissection. What about the safety? Of the 50 patients who underwent transradial intervention, no bleeding, no hematoma, fantastic. And we talked about one patient had a dissection which required stenting. So if you do this case in a OBL or a ambulatory surgical center, from the time they get admitted to going home is 7 hours. From the time of starting the procedure, ending the procedure, and ambulating is 2.7 hours. So in theory, and what I've done is once they've left the cath lab, they can go home in 2 hours, and bleeding is very uncommon, and you could get hemostasis. And I tell them, if you start bleeding again, just get your index finger, just put some pressure on your radial artery, and that should solve the problem. So in summary, transradial intervention reduces access site complications and leads to earlier ambulation and shorter discharge times. Orbital atherectomy with a Diamondback series of devices is the only atherectomy device which allows for infrainguinal treatment through the radial artery, and based upon studies shows a high procedural success rate and treatment success rate. This is John Wooden, and he was the UCLA basketball coach for many years. And the person that he's standing next to is Kareem Abdul-Jabbar, arguably the greatest of all time. And some people could say Michael Jordan or LeBron James. But this is what he would teach his pupils. He would say, failing to prepare is preparing to fail. Thank you.
All right, really good, Michael. I love the John Wooden quote at the end. He was definitely a class act and had more than wins to his credit. Really a great guy. So I think that'll spark some discussion in the time that follows. We're going to move on to our final talk for this session. This is by Dr. Su, who is the Peripheral Vascular Director for the Cardiovascular Department at China Medical University in Taiwan. And he's been tasked with speaking about atherectomy at the subintimal space in the lower limb. Is there a role? So let's hear about subintimal atherectomy. Dr. Su.
Okay. Good day, everyone. So, so as we know, when facing a detailed lesion, when we penetrate the lesion via subintimal space, and can we do the atherectomy here? I can imagine in a subintimal space, the calcified portions inside the lumen, and you are in a subintimal space. The other side is soft tissue, so the weaker side. So theoretically, if you do atherectomy here, the force will always go to the lateral side of the vessel, but rather than to the calcification part. So in the literature review, it is generally suggested to avoid atherectomy device use if you are in a subintimal space, or maybe it's just at least a relative contraindication. So how about the real world experience? I just shared two of my cases to you. The first case is a gesturing case. This patient is a 79-year-old woman with a history of CAD, diabetes, hyperlipidemia, and she suffered from left leg resting pain, and the Rutherford class is 4, and ABI is 0. So the lesion we see here is a distal SFA calcified occlusion. And we penetrate the lesion with a VD18 wire, you can see here. And it's in true lumen proximally, and then looped maybe in a subintimal space. So we use IVAS to check the distal part is in a subintimal space truly. So we do the pre-dilatation with a small balloon and prepare to do the gesturing atherectomy. For the lesion, the proximal middle portion is okay, but you can see when the distal portion is crossed via subintimal space, the gesturing seems to not go to the calcification part, however, just to the weaker side. And later we use a scoring balloon, the angioscope, to try to dilate the lesion more. And you can see it's the initial atherectomy effect with angioscope, still inadequate for the distal portion. I can see here, still not good. So we tried everything we have to use cutting balloon, high pressure balloon, and put a stent here. I can see the expansion distal part is, the stent is not fully open, but seemed acceptable. And we use DCB to finish the procedure. It's the final image. Let's say if it looks like this. Stent here seems acceptable, but the ABI improved, and a 1 year follow-up, the ABI is still 0.8. So another case is a HOG1 case. It's a 66-year-old man with a history of CAD, ischemia, cardiomyopathy, ejection inflation just 20 to 30%, and uremia patient. And he suffered from bilateral pain and cyanosis of right foot. And the baseline ABI is already poor several years ago, about 0.3 over 0.5. And this time the right leg becomes severe, and the ABI is 0 for the right side. It's a prior echo shows a heavy calcification over right common femoral artery, and it's the CT angio calcification everywhere. So you puncture the brachial artery, and it's the image from distal aorta, right side like this, and left side the external iliac have a highly calcified lesion. Also, you puncture the left side, use the wire can cross the lesion via Chul-Min. And for this area, because the lesion is heavily calcified, we use gesturing to deal with the lesion, and post-dilatation with endoscope, and put a stent here. The lesion is okay. Certainly the atherectomy here is via the Chul-Min, but the big problem is the right side. I can see the lesion like this, totally occluded, very heavy calcification. We use a lot of wire, cannot pass through the lesion. So you puncture the distal SFA, and finally the wire can penetrate through the lesion from distal SFA to common femoral to external iliac. However, the wire seems to be the subintimal space. We do the predilatation first, and can see the IVAS here. So the lesion we cross, most of the lesion we cross is in a subintimal space. So from our prior experience, we think to do the atherectomy here may not be very successful based on the prior gesturing experience. So we try to do the balloon as possible so as we can. So we use a 5 millimeter balloon for dilatation for about 5 minutes. However, it looks like this, not very good. So we try to use another kind of atherectomy to deal with the heavy calcification. But you can see we tried several times, and the atherectomy is very difficult to perform, and maybe because it's in a subintimal space, So very difficult to do any atherectomy, even we already pre-dilated the lesion with a 5 millimeter balloon. So you can see the effect is really very limited. So we still use a large balloon as possible as we can to crash from the subintimal space. And finally, and also use a cutting balloon and stent can achieve the result like this. Okay, but still the stent is not open very great. But at least the blood flow is okay. Can see the just like this. So my take-home message is that we do the atherectomy in a subintimal space. I think the result is not so good. It's less effective than that can be done in a Chul-Min. So I think subintimal closing is maybe still a relative contraindication for atherectomy. Okay, thank you.
All right, very good. Thank you for that. I think that does show some of the difficulty that's encountered, and you know, maybe this is a good case for advocating lithoplasty and woven nitinol stents. It really shows how difficult these patients are. So thank you very much. Let's open up all of these last three talks to questions at this point. Dr. Ando's talk, Dr. Lee's talk, and Dr. Su's talk. So we'll open this up to the panel at this point for any questions that you might have. I might start off with one for Michael. From time to time, I'm asked to review cath labs where they've had an unusual rate of adverse outcomes. And one of the things that I have sometimes seen is operators who get overly aggressive with orbital atherectomy. So they will go into very long segment, complete occlusive disease, infrapopliteal. You'll see an initial shot where you see the baseline angiography. The second shot is a wire cross. The third shot is orbital atherectomy. And the next shot is just this blush of dye extravasating in the tissues. What would you say about preventing that scenario? What are the safety tips that you would recommend for orbital atherectomy that keep the numbers as low as the ones that you were quoting?
That's a great question. Looking at experience, in my experience, it's going slow. You know, when you see, let's say in the coronaries, people use rotational atherectomy and they're just using that knob and going back and forth like a windshield wiper. This device is not designed to go back and forth like a windshield wiper. It is literally, you got to let the device do its job. I mean, literally, I'm just allowing it with the momentum of it spinning and orbiting to go forward. There's not much pushing involved. So you just have to take your time. And, you know, not going to, let's say, medium or high speed, stay at low speed. If you still hear a high pitch cadence, it's still atherectomized, it's still ablating. There's no need to go at a higher speeds. So I'll stay at the lower speeds of, let's say, 60,000 until that cadence goes away. So technique is very important. Now, the other issue is if there's a long infrapopliteal lesion from, let's say, the AT from the top all the way to the bottom, perhaps that's not a great case because there's a lot of plaque, number one, and it go downstream and embolize. So perhaps not using it for those patients because you're going to be fishing out stuff for the next 2 hours if you start going from top to bottom. Liberal use of vasodilators, nitroglycerin. I mean, you could give high dose nitroglycerin down the leg and not get hypotensive, similar to what you would see, let's say, you give IV or IC. But it's just using device slowly and judiciously and selectively.
Great. That's very helpful. So it sounds like just being as conservative as you need to be to get the job done safely. Thank you. I'm going to turn it over to other panel members. We have three lectures to discuss. Any questions from my panel?
So I have one question for Michael. Do you have any experience about orbital atherectomy use in a subintimal space? Will it be better or still not work in a subintimal space? And furthermore, for other panelists, do anyone do the atherectomy in a subintimal space and have any good result?
The short answer is I would generally avoid it. However, if there's a short segment with your subintimal and you re-enter and the distance is very short and you have no other options, you just have to be safe, be cautious. But as a general thumb, I'd say no, but select cases where the balloon's not fully profiling and you feel that there's no other options, I think it can be used, but in very select cases.
I used primarily the jet stream when I was doing a lot of atherectomy, and I agree with Michael. As long as there's a relatively short extra, subintimal space, the wire will continue to bias toward the intima, toward this vessel rather than toward the adventitia, and you can tend to cut into the appropriate part of the lesion at that point. And I didn't have any problem with it, but in longer lesions, I found that you get kind of a tissue wrap around the rotating tip, and that can be problematic and painful for the patient, frankly. So I try to avoid that as well in longer dissections.
Bill, what you just said, you might be correct that maybe jet stream is a better option because it's not going to orbit in an elliptical fashion. Maybe perhaps jet stream is a little bit more focused path, as opposed to you don't want to start spinning in 360 degree, circumferential orbits in your subintimal.
Yeah, and it preferentially cuts hard tissue. So again, so long as the wire is biased towards the hard tissue, it's generally going to cut that.
One of the other issues is with directional, you can always cut towards where the lumen is, and that tends to get you away. But one of the key elements is, as Mark was saying with his original question, one of the saddest things is you'll have a nice picture initially, and you go one more cut or you do one more pass, and then there's this big old blush, and that's usually the challenge of these long lesions that I think you were describing, Bill.
Yeah, I mean, in addition to the subintimal space, I wanted to comment on the calcium, and with the advent of lithoplasty, which I assume is not widely available outside the United States, at least in Asia. A lot of the tricks of the trade that we saw here, clever ways of approaching calcium, we've been able to really move to an easier solution with lithoplasty, and what I would say is probably safer as well, with very little distal embolization, almost no perforation. So it just shows you the technology advances that really help us with these difficult lesions.
I'll just add one more thing on subintimal atherectomy. So I still am not a believer in stenting unless it's absolutely needed. So end up doing a lot of CTOs where you end up subintimal, whether you like it or not. In addition to some of the things you just heard, where you want to say, for example, use directional atherectomy, which is what I tend to use because I can choose which way to turn. And as Lauren said, you can angle your cutter towards where the vessel is. And Dr. Shu, I recognize that you tried to do that, and that was an exceptionally tough, heavily calcified lesion that kept recoiling, and you had a tough time getting through. So notwithstanding that, oftentimes you can get through, and you can treat focal areas through the entire CTO where, as Bill mentioned, there may be some areas you had a spiral dissection. If you're very careful, use angulation to understand where the true lumen is cut in that area. But it's specifically and particularly helpful in the entry points and the exit points back from entry into the subintimal space and exit out to the true lumen, where you otherwise may have to put a short segment stent in, but you can treat those areas and actually get a nice lumen. And then what I usually do is do DCB through the whole thing. So I completely agree it's a relative contraindication, but I do think it's relative, and I think there is a role as long as it's done. For me, at least, it's directional because I can choose which way I go and be very cautious about facing the area of disease rather than the adventitial space.
So in my opinion, so in this atherectomy era, the skill to pass the wire into the true lumen will be needed.
To stay in the true lumen?
Yeah.
Yeah, that's always beneficial if you can do that.
Yeah. And I think that if you do manage to stay in the true lumen, then you have the advantage of using the non-directional devices like the jet stream. That'll track over the wire, and directional certainly has the advantage of steerability. But if you've gone through pretty close to the center of the lesion, it's pretty fast to just take a jet stream and drive it through that calcium.
How about the echo? Sorry.
Oh, go ahead.
Sorry. How about the economical issue? So I'm thinking atherectomy device is not needed in all cases, in all couch 5 cases. So could you tell us how to use the atherectomy device properly in terms of the couch 5 lesion?
Lawrence, you want to tackle that one?
Yeah, I'm sorry, Mark. I was muted. Yeah, I think that Sensei brings up a good question. The challenge has always been how much atherectomy is optimal. And really, when it comes to this stuff, and it goes back to this whole idea of lithoplasty and arterial compliance change. And I'm just going to leave that on the side. But if you're really invested in trying to change arterial compliance to deliver drug, Reality was a really good trial in looking at marriage of long lesion, calcified, and looking at outcomes and getting an 80% outcome of 85%. The original thought on Reality was to drive the primary patency, the primary lumen diameter at less than 30% residual stenosis. And the fact is that with directional, we never achieved that. We always looked at the oculostenotic reflex, and our eyes suggested 30% or less, but we never achieved it. And yet, if you get to a 50% or less reduction in lumen and then deliver your drug, you still have a fairly good outcome in regards to primary patency. So but I guess, the murky water is a little clearer today from where we were with definitive almost now 9 years ago to where we are with Reality when it comes to directional atherectomy. I think Liberty also kind of spoke to a fairly good outcome with Orbit in a fairly long lesion subset, but not using DCBs, at least with the Liberty original trial. So I'm not sure if I'm answering your question directly, Sensei, but it seems to me that we just have to get a lumen that is bigger than we started with and under 50% to then allow drug delivery based on the data set that came out of Reality.
Great. Well, thank you very much. I think that's probably going to be the final word. We're getting the cue that we need to wrap up the session. I would really like to thank the presenters for an excellent array of presentations, a lot of data presented in this session. And I'd also like to thank my panelists. Thank you very much for all that you've contributed. And thanks also to TCT Asia Pacific for allowing us to participate in this session.